Now, Rich, your program is an OCM program.
We are.
Are you part of the leadership committee for OCM at your institution?
No, I'm not directly involved.
That was a good thing for me, because what I want to ask you questions about is specifically that. So, because I think one of the things that's been interesting in a lot of programming in the past has been, are the doctors engaged, or is it a back office function? And if you go to prior programs, Meaningful Use and COPE, it became more back office function. You hire lower level employees who go through the MR, who make sure that all the I's are dotted, T's are crossed, boxes are checked, and do the submissions. But if you're really going to change the face of care, if we're going to be transforming to value-based care, then it really has to come down to the individual provider. And so, does that happen at your institution?
Yeah, it does. Although it's been a lot of work. So there's been and I suspect this is similar to a lot of large organizations where when we launched, there was a major outreach campaign, a major education campaign to let everyone know about the program, which a lot of folks just did not know. One, and two, make the steps for implementation relatively pain-free from the practitioners. That's the only way you're going to get buy-in. And so. Currently, we do have a fairly large back office operations in terms of helping us identify the patient, in terms of kind of looking at the metrics and so forth. But this definitely moves downstream and directly affects the way the practices function. And so I can say kind of simplistically that the fact that now we do have to document pain scores, right? We're all doing that now. This is not something that, it's not like we were not doing this previously. Pain is a major facet of what we do in terms of patient care. But now we're documenting it. And the downstream effects in part has been more integration with palliative care. I do think that's leading to kind of better outcomes. And in fact, the initiative has kind of had other effects and programs where, for instance, we've recently launched an urgent care for our cancer patients. And that's something that's absolutely critical. We can't have our patients going through the larger emergency department, and I think that's good for care. And in fact, I just looked at the numbers recently. Since we launched just in March, of the 60 patients or so that have been seen in the urgent care, less than 5% were admitted. And when we look at our ER population, if we send our patients to the ER, 50% of them are admitted. That by itself is an amazing number. And so I have to imagine that's going to lead to financial savings, but more importantly, in terms of patient care, it's an incredible number.
Susan, your background is in social work, and so much of the first 2 years and the requirements that were taken from the IOM for OCM were really about patient navigation. And it seems to me that in a lot of practices, that functionality was looking for who are the FTEs who are going to manage it. Because it may not necessarily have to be a physician function. It may not be a cost-effective solution to make it a physician function. Did the social work community, did it expand within oncology, and even within private practice, not just within the institutional setting, in order to start to meet those demands?
Yeah, absolutely. Particularly in the community oncology arena, we saw an increase in those practices employing full-time licensed clinical social workers because you needed those folks to do some of those core components, the depression and anxiety, the advanced care planning, and you needed them involved with treatment decision-making and shared decision-making to really help the patients and family really understand what had been said in those visits, right? So that it became information that would move them towards good decision-making and positive outcomes, right? We needed to coach them on calling the clinic before they arrived at the emergency room, right? And that education was multifactorial, right? It took the whole system to deploy. You had spoken just a few minutes ago, is this a back end or a front end endeavor? And I think if you didn't do both of those things, you didn't transform your practice in the OCM, right? You certainly needed the infrastructure of folks coordinating and elevating those patients to the physician, but the physician needed a full team. What we're learning in the OCM is the oncologist couldn't do it alone, right? There's no way you can manage all of your OCM patients plus all of your commercial patients and do anything meaningful with that. And so those practices that are doing the best began to look at a patient care from really that IOM approach, that whole patient approach, yeah.